One of our big concerns and things that we're looking at is really what type of risk versus benefit that we're gaining in the real world with our advanced therapies in myeloma. If you look across the US, the average patient in the US gets between 3 and 4 therapies, or 3 and 4 lines of therapy for their myeloma. And as we're always interested in kind of pushing the boundaries, and obviously, when we see a patient in clinic, our big desire is to say, all right, what's the next step? What's the next step? One of our interests was really to take a step back and say, well, what are we really achieving with some of these advanced stage patients? And a lot of this comes out of work that's been done by Shaji Kumar, looking at the natural history of a myeloma patient who becomes dual refractory, so refractory to an IMiD and a PI, and now looking at quad refractory, so adding, not just Revlimid and bortezomib, but then adding refractory to pomalidomide and carfilzomib, now penta-refractory, adding daratumumab. And one of our questions was, what type of toxicity are we exhibiting globally with these type of advanced therapies? So whereas some of the outcomes are marginal, some of the costs, and not just financial toxicity, and obviously there's a large burden of financial toxicity that we need to consider at some level, but the individual toxicity to the patient about administering drugs that ultimately end up in numerous hospitalizations towards the end of life. So, one of our questions is really trying to better understand who will truly benefit from patients receiving these type of therapies when they're quite advanced, when their impact on their overall progression-free survival and overall survival may be minimal, but their day-to-day toxicity may be more profound and may require not only financial toxicity to them and the family, but may require multiple hospitalizations that may take a toll on their physical body.